Next is a keynote address by Dr. Natasha Radhakrishnan. Dr. Natasha needs no introduction. She has an excellent, brilliant academic career with many gold medals. There are many articles in international and national journals. Currently, she is a retina specialist at Chaitanya Eye Hospital, and she is the head of the pediatric retina and UVA department at Chaitanya Group of Hospitals. Over to you, madam.
Thank you. Good afternoon to all. Thank you, Dr. Papa, for this wonderful opportunity. It is a bit of a repetition because the drugs causing toxicity to macula and optic nerve have already been covered. So I'm going to condense my keynote into a short and concise speech, and then let's have some discussion on how to monitor these patients, and I'm happy to answer your doubts. So let's go to how to optimize investigation. So you can't just keep doing everything for everyone. So how can we optimize it best? So we have a lot of investigations that we can do in these drug toxicities. So what to do, what not to do. The common ocular toxicities, this is a long list, but we know the hydroxychloroquine and ethambutol heads the list. I don't know if any of you are familiar with vigabatrin. So many of the babies are sent to us for vigabatrin toxicity by the pediatric neurologist because vigabatrin causes optic nerve dysfunction, toxic amblyopia basically. But they're babies, like less than 1 year babies sometimes, because it is used to treat seizures. So how do you monitor that? So there you can only look at fixation. You can look at fixation and color of the optic nerve. And if there is no pre-existing optic atrophy, then you can advise accordingly. But we will concentrate more on the first two. So factors to consider when you think is it a drug toxicity is to look at the duration of use of the drug and the dose of the drug, and establish if the current ocular pathology that you're seeing is because of the systemic condition that the patient has or due to the drugs. Is it a reaction to a combination of different drugs? Look at the age and the health of the patient and the genetic and environmental factors. So in all these things that we said earlier, clinical history is the most important. So you should just take that few minutes to find out how long the patient has been. So many of them will be sent for HCQ screening, but they are not actually on HCQ now. They would have told the optometrist that I was eating HCQ before, so immediately they're sent. So take some time to figure out whether actually they're on HCQ, what is the dose of HCQ, how long have they been having it. A complete ocular examination to look at all the structures and then assess the severity and the reversibility both clinically and via appropriate imagings. Now in drug toxicity, any part of the eye can be affected, from all the way from the lids to the optic nerve. So there are some, and most of the anterior part of the eye, those drug toxicities will stop with cessation of the drug. We are not too worried about it. If you stop it, it will go off. Or you can treat it because they are more symptomatic. Like you have sulfa drugs that induce ciliary body swelling and produce angle closure attacks. You can have glucocorticoids that can cause open angle glaucoma. You can have busulfan that causes cataract. And cessation of the drug can lead to control of IOP, and the angle closure, of course, will require YAG-PI. So they are all easily managed by us. Another group of drug toxicity is drug-induced uveitis. So when a uveitis patient comes to you, it's important for you to know what systemic drugs they are using, because drug-induced uveitis is also now commonly seen, especially with some of the anti-metabolite drugs that rheumatologists are using and cancer drugs that many of the oncologists are using. Now this is a long list of how you can diagnose drug-induced uveitis. I don't think we need to go into that. But these are the drugs that you have to be aware of. I think one that we always think of is etanercept. Etanercept is never used in, it is one of the anti-metabolite drugs used in rheumatology, but it's never used in a rheumatological condition that has a tendency to develop uveitis, because it causes uveitis, it exacerbates uveitis. And these are the other drugs that can cause, especially rifabutin is something that we commonly encounter, and the anti-TNF alpha drugs also. So let's go to our main topics, the hydroxychloroquine toxicity. I think we've already had a full talk on how it happens, why it happens, and all of that. So I'm just going to give you some practical guidelines as to what you can do. So what would be the most easiest thing that you can do in your examination is your dilated fundus examination. But unfortunately, findings in HCQ toxicity in a dilated fundus examination come in very, very late. So there is no point in screening with a dilated fundus examination. So the next thing that we have in our armamentarium is a visual field testing. Which visual field would you use for HCQ toxicity? 10-2. That is what we have all been following, and it's the easiest to do 10-2. But there is, like ma'am showed in her presentation, there is a subset in Asians who are developing paramacular changes, not parafoveal, but paramacular. So if you want to cover the paramacular area, which is, you can come forward, there are a lot of seats here. No, they're adamant they will stand. Okay, so the paramacular region, if you will miss it if you screen with a 10-2. But practically 10-2 is easiest to do. So I think most of us still follow 10-2. If you see anything that's suspicious in the arcade area, then you should consider doing a 30-2. Then the other most sensitive test that is so easy to do if you have the machine is the fundus autofluorescence. Nicely it picks up that hyper activity in the parafoveal region, even in the paramacular region. And if you have access to an autofluorescence, that is one of the baseline screening tests that can be done at every visit. And of course, once you suspect, MFERG is very nice to say, but how many institutes have MFERG in the whole of Kerala? So because of that, you do it. If you have access to it nearby, you can send the patient for it if you suspect HCQ toxicity. So you know clinically, you and your 10-2 and your OCT and your AF is corresponding, and you want to confirm, you can send for a MFERG. OCT is again more available than the others. So OCT, especially mainly the spectral domain OCT. So it's very important not to use the time domain. The time domain will not give you the early changes. So spectral domain OCT, if you look and if you scan from arcade to arcade, you will be able to detect the early changes, which is loss of the ellipsoid zone in the parafoveal area. So guidelines recommend annual screening after 5 years of use, and additional risk factors are small stature, obesity, liver or kidney disease, and they require annual examination. So what all will you do? Vision, general ocular examination, HFA, like we said, 10-2. Paracentral scotomas are the first finding. They should be non-random depressed points, and they should not be explainable by other ocular findings like a BRVO or something that has previously affected the macula. Then you cannot, say that it is HCQ toxicity. So these are the stages in the OCT that you can see. So the early parafoveal loss of the ellipsoid zone can be seen here clearly, and then it undergoes atrophy. Autofluorescence, these are everybody knows that, I believe, the dying cells are hyper autofluorescent and the dead cells are hypo autofluorescent. Multifocal ERG, of course, shows a depression in the area that is affected by the HCQ toxicity. So again, baseline, you can do if the patient is sent to you, you do a baseline and keep every year after 5 years or more than 1000 milligram cumulative dose, and earlier yearly if any risk factors. Now the problem with us is not all of this. All of this I'm sure all of you know. The problem is when the patient comes to you, what are you going to write and send to the rheumatologist? So what do you say? If the patient is having a baseline macular problem, what will you do? Baseline patient has drusense, both eyes. Anybody? So if the patient has baseline drusense, then it's very difficult to find out the ellipsoid zone disruption, isn't it, in the parafoveal area. So you can write bilaterally if it is there, you write to the rheumatologist saying that or patient has a bilateral hereditary macular dystrophy. If it is very clearly a condition which you cannot follow up HCQ, you write to them saying that keep it within the safer dose because we are not able to monitor the macula because of a pre-existing macular disease. Then do you say that no, please don't give HCQ because we cannot monitor? No. It is their call whether they should give HCQ or not. We can only tell them that if you give HCQ, I am not able to monitor because this problem is pre-existing. If it is a unilateral disease, you can tell them that one eye I cannot use for follow-up, but I am going to use the other eye for follow-up. Now, if you feel that it is an, see, how will you say that it is HCQ toxicity? Everything should correspond. Your OCT finding should correspond to the HFA finding that you had and should correspond to the FAF finding that you have. So, if you have all three of this corresponding, then you know that this is HCQ toxicity. But if suppose one or two are corresponding and the other is not, and you're still doubtful, give the benefit of the doubt. It is not a very toxic drug in the sense that not so many people develop HCQ toxicity, and it is a cumulative toxicity. It is not an idiosyncratic reaction. So you're safe. You can tell that I suspect that there are some early changes. I would like a closer follow-up for this patient. 6 monthly is good enough. You can tell 6 monthly follow-up. Repeat. Tell the patient that you have a suspicion that there is something wrong, but it's a very important drug for you. Don't scare them, because then they will go and eat the rheumatologist's head saying that, oh, I can't have this, my eyesight is going to go. So you have to tell them that this is a very important drug for you and the toxicity is very low, but you're having some signs that make me suspicious. So can you please come back after 6 months? So that is how you can communicate to the patient. And if there is a clear evidence, ask to consider stopping. Again, you don't stop. You don't tell the patient you're losing vision. You have to stop your HCQ. No, because it's a very, very important drug for the rheumatologist. So you have to write to the rheumatologist saying this patient has what appears to be early signs of HCQ toxicity from the investigations that we have done. Kindly consider stopping or switching to another drug, and put the ball in their court. Let them decide whether they want to continue or stop or taper and then switch to something else. Next, we go on to ethambutol toxicity. This is like the most dreaded thing that we are now seeing in our OPD, because there are youngsters going blind, there are old people going blind who were reading before, and then they are taking ethambutol and then they don't even have ambulant vision. So that is really horrible. And in spite of all the efforts by the Uveitis Society of India, we haven't been able to change the guideline for the drug as at present. So we know that it has caused, again, Papa has given a very long lecture on it, so let me not go into the details. Now, baseline evaluation, visual acuity, if you get the patient for baseline, many of the patients are being referred for baseline. So you can do vision, color vision, contrast, visual field. Which visual field? So here we are looking at optic nerve. So optic nerve, 30-2 or at least a 24-2, not a 10-2. Okay, so 30-2 or at least 24-2. 24-2, the advantage I find is that it is faster. HFA 30-2 is going to take a long time. Then additionally, if available, you can do a baseline OCT RNFL and a VEP. You don't need to do a VEP. You can do a baseline OCT RNFL because it's most clinics it is available. And the patient's awareness of the toxicity should be reinforced. As they can check with their smartphone, they can check their color vision, they can check their visual acuity and an Amsler grid if you want, just to tell the patient that he needs to be aware of it, and if the vision drops, to come and ensure a close follow-up. Children younger than 5 years, the risk is not as high as in adults, but it may be difficult to diagnose the toxicity, especially in pre-verbal children or children who are very small. In these cases, you need a high index of suspicion, and it is usually the parents who can report that a previously visually dependent task is not being done now by the child. So again, practically baseline vision, pupil color vision, and you do HFA 24-2 or 30-2 and an OCT RNFL. And here there is, see, HCQ, you have the time to dilly-dally for some time if you want to decide is this toxicity or not. With ethambutol, you don't. If you suspect ethambutol toxicity, the drug has to be stopped even before the patient goes back to the physician. So you have to tell the patient, now till you meet your physician, don't eat your ethambutol tablet. Let us see, you see the physician and then decide whether it should be continued or not. Okay. So here you will have to take that decision sometimes if the patient cannot immediately meet the TB physician. So you have to stop ethambutol and rule out other causes. TB itself can cause optic neuropathy, it can cause chiasmatic disease, it can cause meningeal disease. So it may maybe just a meningeal spread of the TB that has caused this. So you cannot say it is ethambutol toxicity until you have ruled out other causes, and a VEP really helps. Try IVMP for 5 days, give some vitamin concoction as we usually do. One thing that we have found useful in our practice is to check for all the antibodies that we check for in optic neuritis, because those who have these antibodies are more prone to develop ethambutol toxicity than the others. You can't pre-check it because it is expensive and it can't be checked for the whole population, but you can check it for a person whom you are suspecting ethambutol, because if these antibodies are positive, some immunoglobulin to be given and plasmapheresis can help these patients, and some amount of reversal we have seen in ethambutol toxicity. So that is something that you can request your neurologist to do. Can you check for the optic neuritis antibodies, and if it is positive, try some immunotherapy. But it's a very variable response and recovery. Like Dr. Papa said, up to 1 year you can have recovery. You can have patients who don't recover at all, and they just have to accept it. So in conclusion, screening for drug toxicity is important. Recognizing the drug toxicity in time is important. Raising the alarm bell and not taking the decision yourself, but to involve the treating physician with it, taking steps for damage control, treatment if possible, and most importantly, counseling and empathy to the patients who actually develop this iatrogenically. Thank you so much, and let me invite you to Ignite 2025, bigger and better this year, on January 4th and 5th at Kochi. Thank you.
Thank you, Natasha, for that, as usual, wonderful talk. Because she has to go for the other session at 3:30.
You can see with my fancy dress.
You can ask her any questions. If you want to ask her, you can ask any discussions on. So I just want to stress some points. So the thing is, HCQ toxicity, how it is combined with other retinal diseases. So how will you...
That is one of the, like, IJT. So many patients have IJT or PFT, what we say. So once PFT is there bilaterally, then again it is very difficult to monitor your HCQ. So you have to write to the, or if it is a mild disease, again, that is another point I want to say. Suppose it's a mild, just a few drusen here and there, or some mild retinal problem, then you don't have to say that, you can't follow up. You can say that the patient has baseline this, but I'm still going to follow up, because as long as you can make out the parafoveal ellipsoid zone on the OCT, you can follow up these patients for toxicity. But once the subsidence, what we call the retina, has collapsed in a PFT, then you can't make out the layers clearly. So then in those conditions, or if you have a pre-existing, say, toxo scar or pre-existing macular dystrophy, then of course it is impossible to follow up these patients.
One more important thing is the TB meningitis. So patient with ethambutol, maybe the meningitis is the cause.
Meningitis is the cause, yes. So that is why the MRI is very important. Okay. So ethambutol toxicity is more like a disease of exclusion. So you have to rule out other causes before you say it is ethambutol. But you have to you can stop the drug, like just while your investigation is going on. If you suspect ethambutol toxicity, even before the MRI, you can stop the drug, but you have to get an MRI done.
Okay. So to conclude, before HCQ toxicity, to say, what are the tests you do? Subjective test or the tests you do?
Tests we do are of course, vision, color vision is there. Then the fundus autofluorescence and the HFA 10-2 and the OCT, spectral domain OCT.
Not multifocal. ERG.
No, we don't do multifocal ERG. In the whole of Kochi, I think there's just one institute that has MFR ERG.
Okay, thank you.
Thank you
very
so
much.